All right, a little bit better, a little louder. Okay. All right, good afternoon, everyone. My name is Kevin Dixon, and it gives me great pleasure to be the moderator and introduce Erin Unger, who comes to us to talk about endometriosis. Erin Unger works in outpatient obstetrics, gynecology, and urogynecology at Mount Sinai Hospital in Toronto. She also helps instruct PA students at the University of Toronto. Prior to working in OBGYN, she worked at the Los Angeles LGBT Center in Sexual Health, HIV treatment, and prevention. She practices inclusive, trauma-informed care for all her patients. She trained at the Chatham University in Pittsburgh, Pennsylvania. She's originally from Colorado, enjoys skiing, rock climbing, whitewater rafting, quilting, and collecting old cast iron things. If you see her at the conference, don't be shy. Talk to her about her presentation or anything else you want to hear about, I guess. But let's give her a warm welcome of applause and look forward to your presentation.
All right. So thanks for coming to the after lunch talk. If you need coffee, go for it. I know that the post-lunch coma is a real medical phenomenon. So like he said, my name is Erin. I'm a PA in obstetrics and gynecology, and I work with specialists who focus on endometriosis. And part of the reason why I think this is such an important topic for us today is that I see people who have had pelvic pain and these unexplained symptoms for 10, 20 years. And I'm hoping that by spreading awareness, we can bring that time to diagnosis a little bit shorter, okay, and give you some tools about how to proceed when you have a patient who has endometriosis, okay? So, guys, I want, by the end of this presentation, for you to know what are the hallmark symptoms for endometriosis. What is the first line medical management that you could start to get the ball rolling? I want you to feel comfortable counseling patients about endometriosis. I don't want to hear, oh, periods are supposed to be heavy. Oh, periods are supposed to be painful. None of that. I also want to be able to counsel patients about how endometriosis is a chronic relapsing condition, and the treatments that we need to do are often ongoing, okay? It's good to know when to refer to surgical management and who to refer to for optimal outcomes. I want you to be able to counsel about the implications for fertility in your patients with endometriosis. And I want you to know who else in your multidisciplinary team we can loop in to help get optimal care for our patients, okay? So before I get started, how many of you have encountered endometriosis either personally or professionally? Show of hands. All right. So very common. How many of you here feel comfortable managing endometriosis? All right, room for improvement. I like this. Only way to go up. All right, so you need to know about endo, and for a few key reasons. The first is that it affects nearly 10% of people with uteruses. So that's a lot of folks. And on average, there's about 5 years until a formal diagnosis. I'm honestly seeing up to 15 years, which is very frustrating for patients and the providers who are not knowing what's going on. It has lots of impacts on our lives. So it has impacts on fertility, on sexual function. It has impacts on gastrointestinal disease, urology. In severe cases, it can cause bowel obstruction, ureteric obstruction, as well as permanent nerve damage. Okay, so you can have endometriosis infiltrate the nerves of the pelvis and cause debilitating nerve damage that can become permanent, okay? So what is endometriosis? I think a lot of part of the counseling that really needs to come into play, you need to be comfortable with what it actually is and how it actually causes pain. So endometriosis is the presence of endometrial-like cells or deposits of endometrial tissue outside the uterus. Okay, so this could be anywhere in the body. We see it a lot in the pouch of Douglas. We see it along the ureters. We see it along the bowel. You can have it implanted inside the ovaries. You can have it up on the diaphragm. We've seen it in the spinal canal. So it can really go anywhere. And the key to this tissue is that it's hormonally active. Just like the endometrium that is inside the uterus, this is also endometrium. So it responds to estrogen, it responds to progesterone, it cycles just like its friends in the uterus. So there's a picture of where it can be. The answer is everywhere. Okay, cool. So you guys remember the ovarian and uterine cycle charts? And you're like, oh no, this again, help. Okay, so I want you to think about this. And the pathophys of endo is when your ovaries are being stimulated, then they produce estrogen. What does estrogen do to the endometrium? Yeah, it makes it get bigger. And then we get a release of progesterone. And what does that do to the endometrium? Not yet. Yeah. It just stabilizes, right? And then all of a sudden, then there's no baby. And then the uterus is like, well, fine. And then it tears down the decorations and it said, get this out of here, whatever. I'm not going to use the word slough because that gives me the squicks. So anyone else? Right. You shed the uterine lining. Thank you. And shedding the uterine lining is not a problem when there is an exit point, i.e. the cervix and vagina to get out of the body. But if you have endometrial tissue that's hanging out along your bowel or hanging out on your peritoneum, and it's been building up in response to your ovarian cycle, and then it sheds, where does it shed into? The abdominal pelvic cavity, right? And then your immune system comes and is like, what is going on here? There's blood here. We don't like this. There's a problem. So you get an inflammatory response. You get an immune response, which causes scarring, adhesions. You get nerve fiber sensitization, right? You get this whole pain response in relation to the blood that shouldn't be there. Okay. So knowing that it goes with the cycle helps us counsel about what treatments we need to do, and can also help you figure out, is this endometriosis versus one of my differentials? Okay. Any questions so far? We're going to keep this like pretty casual and fun, as much as fun as endo can be. Okay. All right. So with the differential diagnoses, oftentimes they're going to have painful, heavy periods. You're going to be like, oh God, I don't know what's causing this, because there's lots of things that can cause it. Some of the main differentials that you need to rule out include uterine fibroids, because those can cause pelvic pain and bleeding dysfunction, as well as something called adenomyosis. And adenomyosis, has anyone heard of adenomyosis? Okay, what is it? Correct. Yeah. So it's endometrial tissue within the muscle of the uterus. And they classify it as a different disease, but when I'm talking to patients, I describe it as like your half sister, or it's like the half sister or sister of endometriosis. Like they're on the same spectrum. You have endometrial tissue where there should not be endometrial tissue, and that is within the uterine walls. There's some theories that deep endo that's low in the pelvis actually comes through the uterine wall, through an adenomyotic myometrium, and into the parametria and the side walls of the pelvis. Okay, so people with adenomyosis often have endometriosis and vice versa. And we also have patients who have fibroids and endo, in which case sometimes you have all of them. And that's the Mount Sinai bingo card, I guess. I don't know. So symptoms that we typically think of when we talk about endometriosis include cyclical pelvic pain that have some sort of relation to the menstrual period. Again, we want to think, Around the time of ovulation, we have estrogen peaking. Estrogen is what really then builds up that endometrial tissue. And then you have all of the structures who are like, what are you doing here? Why are you growing on me? I don't like this. Sometimes we do see non-menstrual pelvic pain. This is not related to the cycle. This is often later in the onset of the disease, where you have adhesions, you have pelvic floor muscles that are angry from being in years of pain, pelvic floor dysfunction, and you can have nerve damage that is then causing non-menstrual related pelvic pain. Okay. Deep dyspareunia. Whenever you're asking about dyspareunia, you want to ask about where they're feeling it. Are you feeling it on insertion, halfway through, or all the way deep? Sometimes it's all three. But if it's just insertional, that's probably a pelvic floor vaginismus problem, versus deep penetration can be getting into like cervical or rectovaginal nodules, which can be discretely very painful. Okay. We also see things like cyclic dyschezia, which is painful bowel movements. We might see diarrhea. We might see hematochezia in the bowel movements at the time of the period, because we do see endometriosis erode through the bowel, and then it sheds into the bowel, and then you have hematochezia. Same thing with the urine. So it can create a dysuria phenomenon, as well as a hematuria. When people have it in their thorax, we do see cyclical pneumothoraces. So if you're seeing someone come in with pneumothoraces associated with their periods, I want you to be like, do you have endo? Because we might want to look that up. Okay. And there's that. So basically a lot of your history taking, you want to kind of go through the systems within the pelvis and ask, are you experiencing this? Is it related to your cycle? Does it fluctuate with your cycle? And then you can also ask about nerve pains. So paresthesias, hyperesthesias, radicular pain as well. Okay. Any questions about that? Okay. You guys having a good time? All right. Good. Yes, please. But also correct. Well, first you'd want to rule out like PID and tubo-ovarian abscess and STIs, the acute things. Oftentimes you can have an interstitial cystitis type symptom set from pelvic floor dysfunction and from endometriosis irritating the nerves and growing on the bladder. So you would start with ultrasounds. You would, if you thought there was truly an interstitial cystitis, you would refer to urology, who could do a cystoscopy, and they could even do a biopsy of the tissue of the bladder. You'd also want to make sure that they don't have endometriosis inside the bladder, like growing through the bladder wall. It's hard. There's lots of bladder pain that we see. A lot of it has nerve function. Postmenopausal women, a lot of times it's atrophy, like vaginal atrophy, and the alteration of flora. So yeah, you obviously start low. You do the cultures, you would do STI screening, then you would do ultrasounds to look for the presence of endo, as well as site or cystoscopy. Okay. So endometriosis is a spectrum disease. So it can range from just superficial level peritoneal implants to invasive deep disease. And where people fall on that spectrum doesn't necessarily correlate with their symptom severity. And I think that's the frustrating part of endometriosis. Typically, we see superficial endo that's just dotted around on the pelvis. We have the ovarian endometriosis. This is also known as endometriomas. Your large ovarian cysts. You oftentimes in the history that will come up is like, yeah, I've been admitted to the ER for ruptured cysts, or I have chocolate cysts. Has anyone encountered like chocolate cysts? Right, that's endo. And they need to be counseled and referred to a provider who can help them with that. If they have ovarian endometriosis, they automatically have deep disease or stage 4, because that's how severe it has gotten. And some of these endometriomas can get quite large, like up to 20 centimeters. If you're tracking somebody with an endometrioma or the ovarian cyst of endometriosis, you want to track, if it starts growing too big and too fast, it could rupture, and rupturing endometriotic contents into the peritoneum can wind people up in the ICU. Okay, it's very, very not good and dangerous. Okay. There's deeply infiltrating endometriosis, and this is endometriosis that actually invades into the tissues. So it's considered deep once it has invaded 5 millimeters beyond the peritoneal layer. And when I'm counseling patients about endometriosis, I don't like to say this, but I say you need to think of this like cancer. It is not a cancer. You have to be very clear about this. I'm not saying you have cancer, but it behaves like a cancer. It invades. It grows where it's not supposed to be. It crowds out other tissues. It can erode through things that it's not supposed to erode through. It can come back. It can recur. We can treat it through surgery and medication, and oftentimes we need a combination of both. And because patients, when you kind of frame it in the oncology light, they have personal or familial experience with some sort of cancer treatment, and they understand how that treatment goes, and that they're like, oh, okay, this is starting to make sense to me. Okay. We do see the deposits outside the pelvis. So there's the thoracic endometriosis. People who've had C-sections will have C-section endometriotic implants. The thought is that it was an adenomyotic uterus that then the endometrial cells were like, all right, let's go out. And they kind of track the path out towards the abdominal wall. So you can see abdominal wall endometriotic implants or nodules. We also see that in episiotomy scars as well. So if you have cyclical pain with those, you want to be thinking, hey, maybe we seeded some endometrial tissue into that C-section scar. Okay, so you're like, damn, endo's everywhere where it shouldn't be, like literally everywhere. Okay. And then the adenomyosis, I count that as a form of endometriosis personally as a clinician, because they behave very similarly and often they go hand in hand. Okay. Questions about this one? So they have grading systems based on how extensive it is. So if you hear people say, I've been diagnosed with stage 4 endometriosis, like this is where their pelvis is, we call it frozen pelvis. You might see this on a radiological report, frozen pelvis. That means all of the structures are fused together and move as one big block. Another term you might see is something called kissing ovaries. Let's calm down a little bit. Okay, so how are you going to go about making your diagnosis? Right? Everyone's going to say laparoscopy, but who's got a surgical wait list in your area? Our surgical wait list for a non-urgent gynecologic surgery is about 2.5 years. So you want to be able to get your patient to a point of management without laparoscopy. And laparoscopy has downsides as well. So you do a detailed history. You want to know about cyclic pelvic pain, starting day 14 of your cycle through menses. Is it, if they have pelvic pain every day of the month, does it worsen during any point of their menses? You want to ask about pooping, peeing, sex, all of those things, history of infertility, history of ruptured cysts. That's going to be a big high yield for patients who've never has had frequent contact with the emergency rooms, but has never been told that they have endometriosis. You can do a pelvic ultrasound, a transvaginal ultrasound, but you need an experienced sonographer and radiologist to interpret this. So in the clinic, we can spot endometriomas. These are 2 kissing ovaries. So that's where the ovaries are stuck to each other. Like they're kissing. I don't know. It's not cute though. They can also be stuck to the uterine wall. They can be stuck to the bowel. We do something called a sliding sign. So I don't know if you're doing point of care endometriosis, but you push on the patient's abdomen and you see if the bowel slides past the back of the uterus, if the bladder slides, if the ovaries are mobile. And then you'd want to do an exam. So you start with a bimanual exam. You want to feel for any nodules within the vagina. because you can have transmural vaginal disease where there's endometriosis going through the wall of the vagina. If you feel that, then you'd want to place a speculum and look with your eyes as well. You will feel for the cervix oftentimes. So who's felt cervixes before? Like everyone should, right? Normally you can get your finger up around there and feel all around in the fornices, right? Everyone nod. Normally, right? But sometimes if depending on where the disease is, part of the cervix will be buried inside tissue, and you can't like get your fingers on either side of it to test cervical motion tenderness because the cervix is not moving because it's just tethered in place due to endometriosis. You also want to feel the posterior wall of the vagina for a rectovaginal nodule. So this would be a very tender, very discreet area, usually midline. Make sure it's not poop, right? Because you'd be constipated and you'd be like, you don't want to be like a new PA and be like, oh my God, I feel something. And they come in and they're like, that's poop. You're like, noted. And you might be able to sense some ovarian fullness. Oftentimes, if you're actually pressing on an endometriotic nodule, it's exquisitely tender. We don't routinely do speculum exams unless I feel endometriosis inside the vaginal vault, unless you're needing to assess for a cervical polyp, if you need to do an endometrial biopsy, or if they're due for their PAP. Okay. So on the ultrasound, you'd want to talk to your radiologist in the area and see who is the best at gynecologic radiology, because it can be missed a lot of the time. We do MRIs once we have established through ultrasound or through exam that deeply infiltrating endometriosis is present, because that's where the value of MRI really kicks in. It helps with surgical planning. It says, okay, this ureter is compromised. We're going to have to plan for this. We have bowel involvement. We want to have general surgery. We need to be consenting about the possibility of an ostomy. What's going on with the bladder? Is there a low rectovaginal nodule that's going to cause issues with fistula risk or a permanent ostomy? Okay, so once we have this deep disease, the surgeries really step up and become quite complicated. So the take-home point is that if you have a suggestive history, even if the exam is completely normal, that should be enough threshold for you to start going down the pipeline of treating endometriosis. Okay, so even if they have completely normal imaging and a completely normal exam, they could still have peritoneal superficial endometriosis, and that can hurt just as bad as the deep endo. And remember, the severity and extent of the endometriosis does not correlate to the pain the patient is experiencing. We have people come in who have big, technical term, big rectal plaques, and their bladder is completely infiltrated and they have no pain, right? So there's a huge spectrum on their response. So if the history says this is endometriosis, treat it as such. Okay, you have to have a low threshold to just begin treatment. So you think this is endometriosis, now what? You call me at Mount Sinai and be like, hey, that talk you gave, can you help me? And I will say, yes, I can. Please do. So what are you going to do? Okay, I'll tell you. You begin the discussion in treatment and counseling. What I'm seeing is a lot of medical trauma come through because they're like, my doctor just told me to be on birth control pills and sent me home. And then I've been on birth controls off and on for 15 years and none of it's helped. And I'm not going to be on any more hormones. So if we can change the counseling at the beginning of the diagnosis, I think we can have a lot more patient communication and patient understanding about what the treatment plan for endometriosis actually looks like. Okay, so maybe. Does it go forward? Oh, there we go. So I want patients to know that it's a chronic, lifelong condition that can recur and it can progress and become more severe than it currently is. They need to know this. I want them to know that there are fertility implications. Having endometriosis does not automatically mean that you're going to have fertility problems, but it needs to be on your radar and it needs to be on their radar so they can talk about their options and what their priorities are. You also want to know what their fertility plan is prior to initiating any medication, because some are birth control. So that doesn't work. Okay. So lots of things impacting fertility. If you have those big ovarian tumors of endometriosis on the ovaries, are those ovaries going to have like normal ovulatory function? Maybe. It might not shoot into the tube if it shoots at all. The thought is that the inflammatory environment caused by this ectopic endometriosis can decrease egg quality, right? So that even if you did IVF, you would have a lower yield than someone who did not have endometriosis. You can have a fibrosis or a hematosalpinx of the fallopian tubes. And you can also have adenomyosis, which if you're talking about IVF can have some implications in terms of embryo implantation. So you'd want to have a doc on board who knows what to do with that. You also want them to know about invasive disease, and you want to be on the lookout for invasive disease because you'd like to catch this prior to it fully eroding through the sigmoid colon or prior to full obstruction and hydronephrosis. And also there's a lot of psychosocial morbidity that comes along with this. First of all, there's stigma about people not wanting to talk about periods or sexual health. Second, fertility hits a really tight spot for a lot of people with uteruses because it's something so intrinsic, and shouldn't my body just be able to do this? And why is my uterus rebelling against me? Why there's a lot of support that needs to happen both emotionally and psychologically. Okay. Questions about this? No? You guys good? Yes. Yeah. It can decrease. Yeah, it could be. So the latest 2022 treatment guidelines had they said there wasn't enough evidence about treating people like with Lupron or a progestin prior to IVF or after IVF. But from a pathophysiologic standpoint, and really what we're seeing in clinic, I think it does make a lot of sense to decrease the burden of endometriosis in the pelvis, whether that's through surgery or through medical management, to decrease that inflammation and therefore hopefully increase egg quality. The hard thing with fertility, though, is of course there's so many factors that could be at play that it could also be other things. But I do, whenever I come in to a patient who we're discussing endometriosis care, I say, do you want to have children? Have you gotten pregnant in the past? Usually what the first thing I do, because at this point we're talking surgery most of the time, I tell them that they need to go to a reproductive endocrinologist and make sure that their tubes are patent and that their partner has semen that swims and can get there. Because if you don't have a path for egg to meet sperm, then you should just go straight to IVF, right? So it saves people a lot of time, especially when they've already delayed 5 years for their 5+ years for their endometriosis. But adenomyosis can impact implantation and can cause placental factors. So I'll talk about that in a little bit. Yeah. Cool. Or not cool. Another key point that I wanted to bring up is that often we see endometriosis present in adolescence. And this is a really frustrating experience for, I think, everyone involved. They will have persistent chronic pelvic pain despite management, usually with like NSAIDs, Tylenols, and birth control pills. They will also have a lot of GI symptoms. So the nausea, vomiting, like bloating, constipation, just kind of these nondescript symptoms. And one thing we see a lot of is missing school during their menses. So if your menses are debilitating you to the point where you cannot do your daily life, then that is a problem and that is not normal. Okay. I think we have some like Christian, like your period should be heavy. Thanks, Eve. You ate that apple. That we need to deconstruct from our collective mindset. Okay. So if we see an early onset of pelvic pain shortly after onset of period, I want you to think endometriosis. So if you're in primary care, I want this to be on your radar, because the earlier onset, the higher chance that they're going to progress to more severe endometriosis in the future. And if you can control their pain earlier, or at least get them a diagnosis and then get them coping mechanisms, you might hopefully push away any accrued medical trauma that they would otherwise have. Okay, because a lot of people are very upset about not being believed with their pelvic symptoms. And so I want to change that, because endometriosis can do it. I mean, watch House. Like, it's not that, it's not lupus. I want you to be like, this could be endometriosis. Right? Netflix, call me. So just kidding. All right. Oh, there we go. Is that where we're at? Okay. So if you suspect endometriosis, and you don't have to have laparoscopy to prove this, you don't even have to have ultrasonic evidence to prove this, you just need to have a history that is suggestive. I want you to start early empiric treatment if your patient is receptive to this. So usually the first line is a combined oral contraceptive. That works in about 30% of patients. You're like, 30%, that's not very many. No, but for the 30% that it works for, it's pretty good, because it's reliable contraception. We recommend you take it continuously. So that means skipping the placebo pack. And it works out, right? Like they're happy on it. They won't get pregnant if they don't want to be pregnant, and they can control their symptoms for a long period of time. Yeah. No, if they have breakthrough bleeding, we'll have them stop for 4 days and then restart. Yeah, but you don't have to. The idea is that the treatment goal is essentially to stop ovulation and decrease cyclical growth of the endometrium and decrease the flare shed cycle. Okay, so we want to have a lower estrogen and kind of almost a progesterone dominant state, so that things are not shedding. Then we're not having the immune system saying, what is this? I don't like this. Okay. But a key point to starting oral contraceptives is, what number does it work on? 30%. That's not the majority, right? So I would like early follow-up in these patients. So where you're checking in at 3 months, how are your symptoms doing? If they're like, it's horrible, it's worse, I'm in more pain, then you know you're dealing with the other 70%. And you should discontinue the birth control pill, the combined contraceptives, and move to the next level. Some people with their endometriosis are very sensitive to estrogen. And sometimes, depending what pills you're using or just any combined oral contraceptive, you don't have enough progesterone to override the estrogenic effects of that. So it actually can then let endometriosis continue wreaking havoc. Okay. So what's the next step, you might ask? I'm here to tell you. You're going to go on to a progestin. We really like Vizan. You can also do Norlutate or progesterone containing IUD like the Mirena. Most people feel a lot better once they get used to the Vizan. Okay. People who don't respond to Vizan, we will do a GnRH agonist, like Lupron or Zoladex. We'll talk about that in a minute. And then we also have a GnRH antagonist, which is Orlissa. The numbers 3 and 4 on there have a higher side effect profile, and specifically with the GRNH agonists, we don't want to use in young women because it creates such a hypoestrogenic state that we don't want to implicate their bone mass. So we don't like to use that under 23. Oh, yeah. So you would counsel them. You would say, hey, I really think you got endometriosis. We can try birth control pills, but honestly, I think we should try Vizan to start off with, because the studies on Vizan, oh yes, I don't know if you can see this picture. So this is a really cool study where they were tracking a bladder nodule, and it actually resolved after 16 months of being on a progestin-only medication. So we have evidence of regression on a progesterone-only medication. We do see that progestin has an anti-inflammatory effect on endometriotic implants. It also has an anti-angiogenic effect, which can help with slowing the invasion. We don't know we can't predict at this point who is going to respond in terms of a disease regression pattern with Vizan, but we do know is that people's pain greatly improves after 3 months of being on Vizan. They feel better. Their pain is gone. Whether or not it's stopping the growth, we don't know, but their quality of life is improved. Okay. Did that answer your question about yeah, it's fine to go straight to a progestin. If you're doing norlutate, so the mini pill, like the contraceptive, usually isn't enough. You need the higher dose of that. And if they are using that for contraceptive, you need to make sure that they're taking it reliably. Vizan, technically, we're not allowed to say it's a contraceptive, but I think 2/3 of people go straight into an anovulatory amenorrhea. And so they're not going to get pregnant on Vizan, but I'm not allowed to say that. You just say, you're not going to get pregnant on, not technically, it's not technically a contraceptive. So if you absolutely 100% do not want to be pregnant, please use condoms as well. But if I'm a betting woman, which I'm not, but you're not going to get pregnant on this. Okay. Yeah. Question over here. Yeah, absolutely. Yeah. Kylina, so in terms of the intrauterine devices, the Kylina, Lilettas, copper doesn't have any progesterone, obviously. They don't have a high enough dose of the progesterone to see really good symptom control. So we prefer to just go straight to the Mirena. And spoilers, you see on the future slide, I don't know which one, but it's there. You want to replace it every 3 years, because that's when you have the maximum symptom control when you're using a Mirena. Okay. Yeah, the next one on the arm implant. Yeah, I didn't include it in the list because we don't routinely administer it here in Canada. We did a lot in the States, but yes, you can also use that. Yeah. So yeah, the take-home message is that pharmacologic suppression of endometriosis improves people's pain, and it may slow the proliferation and progression of disease in some folks. So it's good to be treated. Yeah. We use Alesse. Sometimes we use Marvelon. Not a lot of the tricyclines. We do use NuvaRing fairly often, just continuously, because some people are going to want to take pills. But frankly, we don't put a lot of people on birth control because by the time they've reached us, they've failed oral contraceptives and not been heard. So this is why if you're starting someone with suspected endo on oral contraceptives, combined oral pills, I want a 3-month follow-up, in person, assessing symptoms. How are you doing, with the plan to switch if you need. Okay. And I want that expressed to them, because the second you say, oh, everyone says, I don't want to be on hormones because I've been on hormones my entire young adult life. And it's hard. And so you have to explain how this is actually, it's a hormonal disease and the mechanism is a hormonal treatment. Okay. Any other questions on this guy? Yeah. 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 So if a lot of people are having uterine cramping, like if they have an adenomyosis or even fibroids concurrently, the actual shedding of the lining is very painful. So by preventing that, you save them some heck, as I like to say. When people are like, well, it's not natural to not have a period, I point out that it's not natural that they haven't had 6 kids yet. And that, like, if you're over 35, like, start writing your passwords down for your imminent death, right? Like, so I say, it's, if we were in the olden days, we wouldn't be G0 at 35, right? Somewhat if you had structural, but just generally speaking. So that kind of helps it. If you're really reluctant, you'll say, you can try it. Let's see how your symptoms are. If you're really not happy when you're bleeding, let's try 3 months of just continuous and see if that changes it. Because sometimes they just need to try it out. But people have the conception that if you don't have your period, something's wrong. And again, I think that's something we need to deconstruct in medicine. Okay. I'd be like, no, it's actually a nice thing. Something, I don't know, maybe you're into it. No period shaming here. So with the progesterone only pills, we start on the first day of the period. We know that we want them to not be pregnant. So it's a good way of knowing they're not pregnant. And then it helps with the not going into abnormal bleeding. Okay. You want to counsel them similarly to an IUD counseling, where you say you're going to have irregular persistent bleeding, like the AFib of bleeding, for the first 3 to 6 months. I tell them, this is not your period, because people are gonna be like, I had my period for 5 weeks straight. I'm like, well, no. Well, and then you prod more and you're like, well, were you feeling, well, how many pads were you using a day? Oh, just 1 or 2. And it was like panty liners. So I've started to counsel that this isn't a period, this irregular bleeding. This is the lining of your uterus adapting to the new hormone setting that it's on. And I've gone so far to explain it as when the wind blows and some leaves fall off, like those were the leaves that weren't holding on tightly enough, and they're just going to come out. So don't panic. I say push through. By the time you reach 6 months, most people are amenorrheic or will have very light regular cycles. Okay. With the GRNH agonist, if you are starting somebody on Lupron or Zoladex, this is very important. I want you to write this down and put it in your mental vault. Start them in the luteal phase of their cycle. Does anyone know why? Does anyone prescribe Lupron? Okay, this is some cool pharmacology. Ready? So GRNH agonist. So that means it's going to stimulate the pituitary to release FSH and LH. And when you initially give Lupron, or a GnRH agonist of your choice, you're going to stimulate the pituitary, which is going to fire off a bunch of FSH and LH. And if you have an ovary that's in its follicular stage, as in pre-ovulation, it's going to be like, let's party, let's do this. And their endometriosis symptoms are going to just explode. Like they're going to have way more estrogen. They're like, it made my period so much worse. It made my pain so much worse. So you want to get it when you're in the luteal phase, i.e. the ovaries have ovulated. And so you can pepper them all you want with as much FSH and LH. And they're like, no, I'm on break. Nope, I'm not going to respond. Okay. So you want to start them in the week before their period. What if they have wildly irregular periods, or it's really urgent that we start them on Lupron? In that case, we add an aromatase inhibitor during the first 5 days of onboarding if you don't know where they are in their cycle. And that will prevent that surge of estrogen from a non-luteal administration of a GRNH agonist. Okay. Second, third shots, doesn't matter. Just that's that first onboarding shot. You want to get it during the luteal phase. We do estrogen or a progesterone add back therapy to help mitigate the side effects of the GRNH agonists. So GRNH agonists have a bad rap on internet reviews. Like people hate Lupron. I think partly that it's not administered at the right part in their cycle, and then B, they weren't educated as to what the side effects are. So Lupron is a medical menopause. It tells your ovaries, you guys can go to sleep now. You don't need to make anything. And you go into a very drastic hypoestrogenic state. So what are the main side effects? hot flashes, skin changes, just everything that people complain about with menopause. So you warn people about this. You say, hey, this might happen. That means it's working the way we want to. That means we're starving out your endometriosis. Works the same way with fibroids as well, just FYI. But we can give them Activel. So what Activel does is it's a very low dose estrogen, and it will just bring up your estrogen levels enough not to stimulate the endometriosis or resume your periods, but enough to take the edge off of the hot flashes. We start everybody after 6 months of Lupron just to protect the bones. And then when I prescribe Lupron, I give them the Activel at the same time to say, okay, this is, if you have hot flashes and you really are not having a good time, you can just start taking it whenever you want. Or after your third shot, we're gonna get you started on it regardless. Okay. And again, like we said, you try to figure out something else for people younger than 23, but if you need to, talk about risk benefit. After 2 years of a progestin only or GnRH therapy, we do a DEXA scan just to make sure we aren't having an osteopenia or osteoporosis. And we counsel everybody to take vitamin D, 2,000 units, as well as having calcium in their diet, stopping smoking if they're smoking, and weight-bearing exercise. Okay, questions about this slide? No? When are you going to give the Lupron shot? Luteal phase. When's the luteal phase? Post-ovulation. If you don't know when they ovulated or where they are in their cycle, what are you going to do? Yeah, give an aromatase inhibitor during the first 5 days of onset of starting of that. Kids are great. This is wonderful. All right. Maybe. All right, other treatment notes. So what we talked about earlier, use a Mirena if you're going to use a progesterone IUD. Typically what we see is that Mirenas are really good for really good for adenomyosis and really good for kind of lower disease, kind of the disease, i.e. that's coming out from the pelvic side walls. It doesn't do a lot in terms of suppressing ovarian disease. I kind of think that it's like it's above Mirena's head and it doesn't know, it can't see what's above it, is how I think about it. So we don't see a lot of endometrioma resolution on a Mirena alone, although some people do become fully anovulatory on a Mirena, but we don't know who those people are going to be. But it is a reliable form of contraception as well. Naproxen and other anti-inflammatories are really good. So sometimes you can pre-medicate prior to people's periods. If they're having really, really heavy bleeding, either from adenomyosis or a fibroid, we do prescribe tranexamic acid in the first 5 days of their periods, which can decrease menstrual blood flow. For people who have pelvic muscle pain, we also give baclofen gabapentin suppositories. You can insert them vaginally or rectally. I counsel people to do it rectally because there's a sphincter and it will keep it in there, unlike the vagina. The other thing I did not mention, we're doing studies right now. We're showing that people with endometriosis have iron deficiency anemia at higher rates than expected. And this is not related to their bleeding pattern. So we think there's some sort of sequestration going on. So if you have a patient with endometriosis, you want to be looking for iron deficiency anemia and treating appropriately, because that can also improve their general well-being. Okay. When I was like, well, they're like, well, I'm not bleeding. Why would I be anemic? I'm like, good question. Good question. So anyways, questions about this one? Okay, cruising along. This is a treatment algorithm. I got it from the guidelines. Basically everything I talked about. It's really small. You can't see it. I'm going to skip through it. If you want it, I'll email it to you. Okay. When we're talking about endometriosis, one of the main complaints is pain. And we have to be very careful on how we counsel about this. The reality is that even if we treat or remove, I tell people, if I could wave a magic wand and remove all of the endometriosis in your pelvis, you still might be in pain. And that's something that they need to know prior to surgery, prior to medical management, that their pain could be coming from their endometriosis, likely it is, but it could also be coming from their body's response to the endometriosis, such as pelvic floor muscles holding contractions. Because what do your muscles do when you're in pain? They squeeze. And then if you're squeezing for a long period of time, muscles aren't designed to do that, right? So then they start to spasm. Pelvic floor muscle spasms are very, very, very painful, partially because they're scary. They're in a part where most people aren't even aware that they have muscles that could be spasming there. It's in this like deep, sacred, like primal part of your body. People can't see it. It's not like back pain and shoulder pain that everybody knows about. And so they can have these big spasms, like your psoas muscle spasming. That's going to hurt, right? Like it can hurt a lot. So that's when people are asking about ER visits. Sometimes it's a major psoas spasm that you need to calm down. And that's what we use the baclofen gabapentin suppositories for. So you get the antispasmodic plus kind of a shh to the nerves. But those work best in the setting of a skilled physical therapist who can then like get in there and get the muscles like reset, so to speak. We'll also do Botox injections into muscles that are hypertonic and spasming, and then so that you can make progress with the physical therapist. So we want to explain to them that the pain could be coming from other things. Usually I say, pelvic floor pain is frustrating because you have to work through it. Like you got to do your PT stuff. Like nobody likes to do that, but we do it, and then OHIP doesn't cover it. So that's annoying. But you have to counsel them that they might wake up and still be in pain, but it's not from the endometriosis. Now it's from the adhesions, the scarring, the pelvic floor dysfunction after being, what I say, in 20, 30 years of pain and medical trauma. And you add in childbirth trauma, you add in sexual trauma, and there's a lot of reasons why there's going to be a lot of pain within a pelvis. Okay. If you do have nerve entrapment, even if you're able to disentrap it, is that a word? I don't know. Unentrap it, detrap, whatever. The nerve, shortly after surgery, about 6 weeks, will wake back up again. And when the nerve wakes back up again, it starts crying, freaking out, and everyone's like, why do I have nerve pain again? I don't like this. This is a phenomenon called post-decompression nerve pain. It lasts about, on median, 6 to 8 months. So it can last a long time in people. The main treatment is going to be gabapentin or pregabalin, some Cymbalta, amitriptyline, your favorite cocktail, whichever you want. And just counseling that, no, it's not, you're not back at square one again. This is telling us that your nerves are waking up. You can equate it to like a waking up foot or something like that when it hurts. Okay. For obvious reasons, we want to stop using opioids, or we want to avoid using opioids. We do see that there is a tendency. Studies have shown that if you have used opioids to treat your endometriosis, your likelihood of becoming pain-free or in a remission greatly decreases because there's been a central sensitization and there's a complicated pain relationship that has developed. So you probably want to have a pain specialist on board. Okay. When to refer for surgery? Okay, guys, I got 5 minutes. I'm going to talk a little bit faster. So you refer to surgery if you need to help for fertility, or if you have deeply invasive disease prior and you want to avoid bowel obstruction or things like this. Otherwise, or if you have failed conservative management. We want to avoid multiple laparoscopic surgeries because each surgery increases abdominal adhesions and will make each subsequent surgery higher risk, with higher risk to surrounding structures. If you are sending somebody to a surgeon for an endometrioma ovarian removal, you need to counsel them that by operating on the ovary, you can greatly decrease the functional reserve of that ovary. So you want to have an AMH on them. You want to maybe have them go through a cycle or two of IVF before you go and touch that ovary. If you're in a pinch and they need to drain it in order to access it to do IVF, then usually we'll suppress them on Lupron for 3 months, go in, drain it, and then go do an immediate cycle. Endometriomas have a 50% recurrence rate. So you want to work hand in hand with your reproductive endocrinologist to help with that. We do see that on peritoneal endometriosis, by going in and just doing excisional removal of the endo, the live birth rate is higher in the subsequent year. Not so much the same with deeply infiltrating endometriosis, but the thought is that reducing the endometriotic and inflammatory load can improve egg quality and ovulatory function. We don't have good data about endometriosis suppression before or after surgery or for fertility purposes. But if people's pain is better, then that's a benefit to do. But you don't do it for the purpose of fertility preservation or fertility boosting. You do it for symptom control. With deeply invasive disease, we really are going to be worried about ureteric damage. Lots of people are going to have stents, and you need to have a urology team on board. And we do see fistulas. Okay. So we want to do excision over ablation. You want to cut it out rather than zap it out. And you want to limit the number of laparoscopies that they have. The goal is to have one really good, well-timed, skilled endometriosis surgery, and you're done. Because these surgeries are not simple. They are very high risk for injury to bowel bladder, needing an ostomy, things like that. If you have perimetrial disease or adenomyosis and the person is not planning on going on to have more children or any children, consider doing a hysterectomy at the time of your endometriosis surgery. Sometimes we'll even say, go have your babies and then come back and we'll do all of your endo surgery all at once. We do tend to leave the ovaries because we don't want to kick into a surgical menopause because that has negative side effects for bone, brain, mood, things like that. I like to do an early referral for fertility just to start the conversation. They can get into a doctor that they like. They can start saving money. They can get the lay of the land on what their family needs to do. I do say, you can say, consider moving your timeline up for pregnancy in case it does take you longer to conceive, but we don't say, get pregnant to treat your endometriosis. Because if you thought Lupron was expensive, I do counsel them to try to breastfeed for as long as they can, because that is in a progesterone dominant state. And I often like to place an IUD at the 6-week postpartum visit to help with suppression. Sometimes we'll put them on Vizan. Vizan and breastfeeding is conflicting on whether you want to do that. Obstetric outcomes, we do see higher risk of early trimester loss, first trimester bleeding, placental problems, and preeclampsia. The rates aren't high enough to warrant additional screening beyond what is normal, but your OB that you're referring to ideally would have some experience with endometriosis and would you want your OB to know that you have endo. So we do placental growth factors. We have everybody on aspirin if they have endometriosis to help with placental insufficiency. And we'll do placental growth scans as well. That's too small to read. Lots of people are going to ask, can this cause cancer? And the short answer is no. It doesn't increase the risk of cervical or uterine cancer. There is a slight increased risk of ovarian disease, but on a population level, it's not an increase enough to lose sleep over, does not increase breast cancer risk. And this is independent of oral contraceptive use. Okay, so you just say, no, it is not cancer. It does not convert to cancer. Although we do remove people's appendices when we're doing endometriosis surgeries, because there is some relation between appendiceal cancers and endometriosis. So heads up on that, always check your pathology. Supportive treatments, we talked about this a lot. Pelvic floor physiotherapy, you get a psychotherapist on board. We need to have pain management, healing the medical and physical traumas that they may have come through, and kind of grappling with the realities of a chronic pain-based disease. Acupuncture and other based treatments, people report that they feel a lot better on that, and that's what's important, but we don't have data on how efficacious this is. I say, if it helps you, that's great. The main downside is money. So if money is a concern for you, like I'm not going to say go do this because it's going to help you, right? But it might. So counseling patients, never minimize their pain, whatever the cause, they are feeling it. They need to know why they're in pain and why treatment is hormonal and why the pain may not fully resolve with medication or surgery. Having those questions answered head on really helps people in their response to this disease from a spiritual and mental sense. Okay, I'm getting the time's up thing. I had a vignette, but she's got endo. Ready? Ping, endometriosis radar, cyclic pelvic pain, pain with sex, ovarian cysts, pain with pooping, missing work, 12 years of unresolved diagnosis. You'd be like, maybe this is endo. Okay, 202. Whew. Questions, comments? Oh, and failure of birth control pills. So they're like, birth controls didn't help me. Don't you dare put me on another hormone. You're like, oh, you might have endo. GYNQI is a patient portal education website. They have a bunch of handouts about common diseases and what the treatments are, and you can email the patient from that website. And if you watch the Vizan video, you'll see my mug being like, Vizan. So this is what you need to do with endo. Okay. Usually it's called a core muscle related. So you get pain with you have lesions in the bowel or active and you try to land on the bowel as you have to do there, then you get a bowel that can be very, very difficult. Then if they actually erosion into the bowel, then you will have painful like bleeding into the bowel. So for you can see that most of the time, you use the clinical diagnosis essentially. In my practice, we always have access to a lot of investigation anyway. Yeah. Or radiologists would be able to read a yeah. So with that being said, if you clinically suspect that someone has endo, but you haven't confirmed it is anyway, and they were to get pregnant, would it be, contraindicated at all? Let's say they didn't have endo yet, and it's 5 minutes, so you put them on ASA for the percent. Yeah. Is that, are we doing an overall benefit or are we if they kind of get early pregnancy loss, that would maybe be fine to put them on an aspirin. If they have some program, some of them you don't want to, obviously. So kind of I think it would be from what you're fighting sensitive things. At least in the baseline ultrasound, you're going to know thyroid is present. So that can help your disease. There's no thyroid scanner agreement. But stop at 30 because you don't want that. Feel free to ask another question. Don't be here until. Thank you very much.
Hi, my name is Leslie St. Jacques, and I'm the past president, and it's my pleasure to introduce our next speaker, who is Alexa Mosquella. Alexa is a first-year medical student at the University of Ottawa. Prior to going to medical school, she completed an honors Bachelor of Science at the University of Toronto, graduating with a double major in biology for health sciences and psychology, as well as a minor in chemistry. Subsequently, she had completed a year of the physician assistant program at McMaster University, where she became involved in clinical research to understand the patient experience in primary care practice. Alexa is passionate about increasing access to high quality care and advocating for interprofessional team-based healthcare systems across Canada. Welcome, Alexa.
Thank you for the introduction. All right, I'm just going to test this out real quick. Okay, perfect. I inserted quite a few animations, so I want to make sure that works. But hi, everybody. My name is Alexa. I'm a first-year medical student at the University of Ottawa. Thank you so much for having me here today. I'm super excited to be here. And today I'll be presenting my research with Kristen Burrows, who is the Assistant Dean of the PA program back at McMaster University. And together we were investigating patient satisfaction of primary care PAs in Ontario. So to start off, I have a few objectives for the session. First and foremost, I want everyone to be able to understand the importance of patient satisfaction as a key facilitator of successful PA integration, not only into primary care, specifically we looked at primary care in our study, but throughout the entire Canadian healthcare system. This is really important. Also, to identify various components of patient satisfaction. We've identified and described quite a few in this study, but especially those experienced by patients receiving care from primary care PAs. And finally, to determine the level of patient understanding of the PA role versus other providers, which is something that we also looked at. In terms of disclosures, I have none. I have nothing to disclose. I wish, as a broke student, I wish I had some kind of financial affiliations, but I don't. So no disclosures for me. All right, so we'll start off by talking a little bit about primary care. So primary care really does serve as the backbone of our entire healthcare system. And it's patients' first point of contact with the healthcare system. It's where they go to get conditions diagnosed, to treat and to manage conditions. It's also patients' gateway. Sorry if I'm too close to this mic, please let me know. It's also patients' gateway to other healthcare providers like specialists or social workers that can further help with diagnosing maybe more complex conditions, more obscure conditions, and also just helping to manage and treat disease as well. Oh, right. And primary care is very diverse. We do a lot of different things in primary care. It's cradle to grave care. So we're seeing young newborns all the way to geriatric patients. And so we provide a lot of different services. So we see kind of comprehensive lifelong care in this setting. And we do know that high quality patient focused primary care is associated with a plethora of positive outcomes, including decreased emergency department visits, fewer hospitalizations, lowered healthcare costs to our system, and then also just better health outcomes for patients. So it's really important that our primary care services are accessible, but that they're accessible in a timely manner. So when patients need them. However, I'm sure we all know as clinicians, access to primary care services is becoming increasingly difficult. Health Quality Ontario actually found that of Ontarians who have access to a primary care provider, only 44.3% can actually see that provider within 24 hours of requesting a consult, which is a really bad number. And this number was actually taken before COVID, so it's likely gotten worse. We know COVID forced a lot of clinics to either reduce their operations, function at a reduced capacity, or even close down entirely. So that's likely exacerbated this. We also know that there's been increasing rates of disability, increasing rates of chronic disease, and physician shortages that also contribute to this. So a lot of things to think about here. However, we do know that one great solution to this problem is the introduction of physician assistants into primary care practices. So improvements in primary care services due to the introduction of PAs has actually already been demonstrated in Canadian literature. So there was a study done by Bowen et al. Out in Manitoba, and they looked at 6 primary care practices, and they found that by introducing PAs, they were able to increase their appointment accessibility. They also increased patient attachment to their clinic, so increase the likelihood that the patients would come back to that clinic to receive care. And then also enhanced work-life balance for other providers and other clinic administrators at those clinics. So really, really great benefits. And we see that PA introduction really enhanced the efficiency of these primary care services that were being able to be delivered. So we know PAs enhance efficiency, but something that has yet to be looked at in Canadian literature is the patient perspective of receiving PA services. How satisfied or are patients satisfied with the services that they receive in primary care from primary care PAs? And it's really important to investigate this because patient satisfaction is a key facilitator of successfully integrating the PA profession. Like I said, not only in primary care, not only in Ontario, but also in Canada. So, sorry, I lost my place. So from previous studies, we do know that patient satisfaction correlates positively with compliance, so increased compliance of patients with their medical advice. Also, longitudinal care, better health outcomes for patients, and also continuity of care. And we know that successful PA integration will not be possible without patients' acceptance. So we really, really need patients on our side. So that was our goal. So our goal was to investigate patient satisfaction of primary care PAs in Ontario, and also to evaluate the patient understanding of the PA profession. So do patients know what makes PAs different from other healthcare providers? Because that also can be a proxy for how well PA integration has been up to this point, but also areas where we need to improve. All right, so in order to investigate our goal, we developed a survey called the Physician Assistants in Ontario Patient Satisfaction Survey, and we distributed that survey to patients after their primary care appointments with PA. So after their visit, they were invited to take the survey and they were able to sit down and complete it in clinic. So there were three main parts to our survey. First, we collected demographic information about the patients completing the survey regarding patient age and also gender. We also asked about the patient's reason for their visit to the primary care practice, also about their understanding of PAs versus other providers like MDs, NPs, nurses. And then we also asked about the satisfaction of their care they received from the PA during that visit or other visits, how easy it was to book an appointment with a PA, and also the likelihood of them recommending a PA in the future to family or friends. Most of our questions were multiple choice with preset responses. However, there was a write-in option for each question. So if patients felt that those preset responses didn't correlate with how they were feeling, they were able to write that in, and we analyzed that as well. And some questions were exclusively short answer, and patients were told that they could skip any question that they wanted. So in terms of our data collection and analysis, we recruited patients from 4 family medicine clinics across Ontario that had employed full-time PAs. And this was done by snowball sampling from phase 1 of this study. So phase 1 actually interviewed PAs, NPs, nurses, MDs, and other clinic administrators in primary care to gauge their opinion on PA integration. That was relatively recent in that clinic. So that was phase 1. So phase 2, which is the study, was more focusing on the patient perspective. And we used simple descriptive statistics to analyze our multiple choice responses. That was done via Microsoft Excel. And then we conducted a thematic analysis to analyze all of the write-in responses from both the short answer questions and the multiple choice. And our study was approved by the Hamilton Research Ethics Board. So in terms of our participant demographics, we had 66 participants, 16 were male, 49 were female, and 1 was unreported. And our average patient age was around 48.5 years old with a standard deviation of 16.4 years, which is to be expected because we do know that primary care is incredibly diverse in terms of the patient demographic that we receive. So that was something that was kind of in line with what we thought we would receive. So in terms of our results, our study identified several themes that were consistent across all participant responses, but we grouped them into 2 broad categories that corresponded to our first 2 goals. So first, patient understanding of the PA role versus the MD role. We decided to focus a little bit more on the MD role because that was constantly being compared to the PA role. So we honed in on that. And we had some themes for that category. And then our second category was, again, patient satisfaction with family medicine PAs. And again, we developed themes around that as well, which I will discuss in the next coming slides. So first and foremost, patients do have a robust understanding that PAs provide similar care as MDs. Around 40% of our patients said that PAs are most similar to MDs. 22% indicated that PAs are most similar to residents. So overall, the majority did relate PAs and PA services to MDs. So I pulled some quotes from some of our participants. So this participant said, I get the same treatment from both an MD and a PA. PA offers very comparable care to that of a doctor and NP with the same end results. They, MDs and PAs, are equally knowledgeable. And patients further understand that PAs provide a lot of the same services as physicians do. So here's another quote: both MDs and PAs fill my prescriptions, both do my health checks, both do my physical exams. So overall, there is this robust understanding that there is a lot of overlap between the PA and the MD roles. So patients also understand that PAs are not working in isolation. They're collaborative healthcare providers, and they collaborate with MDs, which is an accurate understanding of the profession, which is great. Oops, sorry, I went ahead. So this patient said, I feel as though PAs and MDs work as a team. And another patient said, I have complete trust in my PA. If she doesn't know the answer or best treatment, she immediately consults the doctor, and I leave with a plan. So we know that patients are really appreciating this collaborative aspect to healthcare as it results in favorable outcomes. So for example, leaving with a concrete plan. So patients also understand that PAs are trained as generalists, whereas MDs are trained as specialists. So patients did disclose that they know MDs go through specialty training, and they go through more years of education compared to PAs. So again, that's an accurate distinction of the two professions. And we found that 86% of our participants disclosed that they had no confusion about the PA role, which is great, but 14% did. And that confusion centered around a lot of different pieces, which was highly variable across the responses, but mostly centered around PA scope of practice and confusion between PAs and physicians in training. So another interesting finding is we found that based on patient understanding of PAs and MDs, we observed distinct provider preferences based on type of medical visit that they were coming in for. So we see that there is a PA preference for a few different types of visits. So for example, routine vaccinations, 65% of our patients preferred to see PAs, annual physicals, 55%, medical forms, also 55%. And overall, a PA preference was indicated when this decreased patient wait times, also increased the appointment duration. So being able to see a healthcare provider for a longer period of time resulted in a PA preference. We also saw a PA preference from patients who were more familiar with the PA. So if they were more familiar with the PA, they had a higher likelihood of requesting to see the PA. And also we found that patients preferred to see PAs for follow-ups or other routine concerns. We also found a comparable preference for other types of medical visits. So you can see here, palliative care, 17% preferred to see a PA, 21% preferred to see an MD. In terms of chronic disease management, 33% for a PA and 40% for an MD. In terms of new and acute issues, 47% for PA, 35% for MD. So we did observe a comparable preference there. And we also saw an MD preference as well. However, when an MD preference was indicated, this largely occurred when the patient perceived their healthcare concern to be more complex in nature. What was interesting is what patients identified to be more complex was highly variable. So some patients identified acute concerns to be very complex, and other patients said, oh, that's not complex. So that was interesting. But when patients did perceive that their healthcare concern was more complex, they preferred an MD, and they stated, well, I think this might need, more specialty training or something along those lines. And then we also saw the same preference that we saw with PAs. When patients were more familiar with an MD, they preferred the MD. Whereas when patients were more familiar with the PA, they preferred the PA.
fine. Yeah, the cumulative results section was quite variable. What was the other option provided? No preference?
Oh, in terms of, yeah, so some patients didn't respond to this question. Some patients indicated multiple options within, preferring PAs for these types of appointments or preferring doctors for these types of appointments. So the numbers might not necessarily add up because patients were allowed to select multiple responses. Some didn't select responses at all. So that might be some of the. As option, well, we did indicate if we did ask if patients believed that they were similar to NPs or registered nurses, and that wasn't. We didn't have specific types of visits for those two providers. All right, so now to move on to our second category. So in terms of patient satisfaction with family medicine PAs, there was an overwhelming response. I think every survey that I read, I found this exact same response. Patients really, really value the timely access to medical care that PAs can provide, which is huge. So 79% of our patients said that PAs provide same-day appointments in their primary care clinic. And this was a really big deal because a lot of the responses we were seeing were, it takes weeks, if not months, just to see my family doctor. And then I'm ill for longer periods of time. I don't know what's going on. I don't have any answers. And that causes a lot of frustration. It also causes anxiety and it, makes things worse a lot of the time. So this was a really, really big deal for patients just to be able to see someone and receive care in a timely manner. So we can see this patient here. They said they preferred to see a PA. There are very long wait times to see a doctor, and with current medical issues, wait times such as weeks can be ineffective and patients remain ill for longer. We had another patient say it's a lot more convenient and scheduling is much more available. So sometimes I think we forget just the difficulty of trying to make an appointment often deters people from wanting to even just call and ask for an appointment. So the fact that scheduling an appointment with a PA has become so easy really encourages people to seek out healthcare services when they need it. And that's what we want, right? Like as clinicians, that's our end goal, to be there for our patients. So this was a really, really great finding for us to see. Okay, so next, patients really valued the increased appointment time that they were able to have with PAs, because overall, this allowed more time for discussion. This allowed patients to feel like they could better understand their diagnosis, that they could better understand their treatment options. And overall, they just felt that communication was a lot more thorough in the patient interaction. And they felt like they had a more comprehensive appointment as well. We also know that patients feel that PAs were able to establish strong therapeutic alliances with them and very strong rapport. So an aspect of that is obviously a result of the communication, but there is also other aspects to this too. So our patients really described that they felt that all of the PAs are very empathetic to their healthcare concerns. And especially when it came to discussing sensitive diagnoses or sensitive topics, empathy was something that routinely came up in patient responses. They also valued the technical skill and medical knowledge that PAs brought forth. A lot of our patients said, yeah, I can't tell the difference between how much my doctor knows versus how much my PA knows just from that, one interaction that they have with them. So the technical skill and medical knowledge that PAs bring to the table is definitely recognized by patients, and it's something that they value and they appreciate. All right. So this is my favorite stat of the entire presentation. 98% of our respondents indicated that they were very satisfied with the PA's ability to address their medical needs and would recommend a PA as a primary care provider to family or to friends. So this is one quote I pulled here. I feel very comfortable bringing my medical concerns to my PA. She's very knowledgeable and compassionate. I'm always satisfied with my visits and my questions are always answered. And then another patient said the PA was very thorough. He answered all of my questions, so I could understand his answers. He was just very helpful. So really, really great things to see. And also just reaffirms all of our previous findings. Okay, so in terms of our discussion, I'll summarize briefly all of our findings. So patient satisfaction was seen due to a variety of components. First and foremost, fast service. So increased appointment accessibility was something patients really, really valued. Increased patient provider interaction time. So again, that more time for discussion was really, really important to patients. And it's something that they didn't have necessarily with other healthcare providers previously. And this allowed them to get a thorough understanding of their diagnoses, treatment plans, et cetera, et cetera. And then also technical skills, like we mentioned, medical knowledge and capabilities, and also interpersonal skills such as empathy were consistently listed as very important. Okay, so there are a few limitations I do want to point out. So first and foremost, our study targeted clinics where there was stable PA employment. So PAs were deemed successful in these clinics, evidenced by low employee turnover and also sustainable funding models, which we know unfortunately is not the case everywhere. So that's something to keep in mind. And all of our participants in this study were patients of PAs. So just by having more interaction with PAs, they probably know more about the profession than the general population does. However, this is the population that we wanted to target because we could have easily found the opposite result, despite having patient encounter or despite having appointments with PAs, patients could have still been confused about the difference between a PA and a doctor. A lot of patients that go to primary care are really just looking for answers or they're looking for medications and things like that. And so it was really important for us to know, are we doing enough patient education when we have these patient interactions about what the PA role is and what makes PAs different from other healthcare providers? And we did find that there is effective education in this population. And then also the longitudinal nature of primary care. So in primary care, you're often seeing the same provider over the course of your life, really. So there are lots of opportunities to interact with that same provider and a lot more opportunities to build rapport compared to acute care specialties where you're having one interaction with a provider. All right, so in terms of our discussion, in terms of patient understanding of the PA role, we did find that patient education of the PA profession has largely been effective in the population of patients that are being seen by PAs. However, there is one caveat to this where I think education can be improved. So like I mentioned before, we did see an MD preference for patients' perceived health concerns that were more complex. So as patients perceive their healthcare concern to be more maybe difficult to diagnose or difficult to treat, overall more complex in nature, they preferred an MD. So that's an area where I think education can be improved because we can inform patients that PAs are trained to treat all medical concerns within their directives. So that's something that we can continue to reiterate. All right, so we talked about a lot of things. And I think I zoomed through that actually, but we talked about a lot of things. We talked about appointment accessibility, increased appointment duration, technical skills and medical knowledge, and also interpersonal skills. These are all aspects of patient satisfaction that were described on part of PAs in primary care. However, the take-home message from this entire talk is that these factors all connect to enhance PA integration. At the end of the day, our study found that we have patients on our side. They're valuing the work that PAs are doing. They're giving us concrete factors that would really help drive forward PA integration, not only in primary care, but also throughout healthcare in Canada. And so it's really important to remember that all of these factors kind of connect to drive home that goal of PA integration. We're not an extremely new profession to Canada, but we're definitely on the newer side. And I think there's a lot more that can go into advocacy and integration in Canada, especially if we look at our partners in the States. All of these aspects and all of this patient acceptance really goes towards driving this goal. All right, so to conclude, patients are highly satisfied with the role of PAs as physician extenders. Patients also support and they accept primary care PAs in Ontario, but there are definitely some areas for future research that we can continue to look at. So again, PA acceptance in acute care specialties where we don't have that kind of longitudinal nature of primary care, and satisfaction can be measured based on one patient encounter. And then two, also the non-PA patient understanding of the profession. So really looking at the PA role awareness and understanding of PAs in the greater patient population, especially amongst patients who don't see PAs regularly. So how much do people really know about this profession beyond clinic is something to keep into account. And then in terms of acknowledgements, first and foremost, my PI, Kristen Burrows, she's been so supportive of me and has really supported all of my goals and has helped me along the way learn a lot about research. It's my first research project. So she's been absolutely lovely supporting me in that. Also my classmates, the class of 2023 at McMaster, they're off doing amazing things in clerkship. So they're very busy right now. And then overall, McMaster University, the PA program there has really made a huge impact on me, not only as a future clinician, but also as a person. And I'm definitely going to take everything I learned from my experience in the program into my future work as a clinician. So I have a lot of gratitude and thankfulness for my classmates, my PI, and overall the program. And now I will open the floor to questions. Thank you.
I think these are all things that we can apparently know relatively easily, but it's great to see the number. But fantastic. You know, one thing that comes up consistently in my practice, patient knowledge, I work in patient as it's not really not but I will oftentimes be transparent about the result of tests for the plan. And I'll be like, hey, anyone's ready this? No, it was the person telling me. And I'm like probably the fourth provider I've seen.
Yeah.
So I'm just wondering if it came up with your research about like transparency of results or like treatment plans with PA versus or anything like that.
Yeah, that's a good question. So I think probably with the nature of primary care, patients are going to their appointment expecting something. You know, maybe they have like some kind of diagnosis, or maybe they have some kind of symptom that they want to get worked up and things like that. We didn't really hear anything about like I'm sure PAs have delivered results, but that wasn't something that we really heard in these in our patient responses. But I think in primary care, when results are delivered, especially like critical results, they're oftentimes delivered over the phone, or an appointment is made to talk about, you know, a difficult diagnosis and things like that. So patients kind of know, I guess, when they're getting a call or, you know, when they're coming into clinic for a result. So I think just like the nature of the specialty might be different. And we exclusively looked at primary care just because we know that that's an area of huge need, and not that other specialties don't need the help. I think we all need the help in the Canadian healthcare system, but nothing specific like that. But I think it just has to go with the nature of primary care. Yeah. It's really sad. Yeah, it's really sad, honestly. Yeah, it is very sad. But that was one thing that we found, you know, that increased time for discussion, increased time to really understand what was happening is something that was really important to patients. So along those lines, there's definitely that similarity. Yeah. Any other questions? No? Oh. Doesn't matter. Mm-hmm. Yeah. In my practice, it was definitely also I just feel more like yeah. Yeah, what came up most in our research was the time to discuss diagnoses, like the time to discuss the symptoms that they were experiencing, also what these big diagnoses meant in like simple terms. So it really was the discussion that we found in the study. They felt overall that the appointments were more thorough. Some of that went along with physical exam, but I would say the bulk of patient responses really just appreciated the diversity of discussion that they were able to have with a healthcare provider. Because a lot of the times, maybe seeing an MD, they were, you know, kind of rushed out of the room saying, you know, let's book a follow-up or things like that. But they felt that, you know, having that increased appointment time with a PA allowed for more of a thorough understanding of what was really going on, which, you know, as clinicians, I think like we've been trained, we have the knowledge, we know what's happening in terms of like a pathological standpoint. But a lot of the times, like, you know, patients are left in the dark just because these appointments can be so fast, especially in primary care. It blows my mind, even as a student. I don't have too much clinical exposure yet, but things just, they go fast. And so as a patient, when you don't have that knowledge behind you and you know something's wrong with your body, just to be able to understand it really gives you like a huge sense of peace. So I can totally understand that. Yes. Right.
But it also may be that they're better at setting the stage for the report, things where they can do that. So I do not know in these clinics, or do like PAs have X number of minutes compared to the doctors having one.
Yeah, you are absolutely correct. And I was actually thinking about this the other day when I was writing my paper. We didn't collect information regarding the true appointment length between a physician or a PA. So unfortunately, I don't have the answer for you, but that is a very real possibility. And that would be very interesting to evaluate in the future, because you're right, it could just be good, or it could just be the fact that PAs know how to communicate things a lot more efficiently. Who knows? Right. 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 Yes. So the information I know would definitely be there. I was actually brought onto the study after the data was collected. So I don't think we collected that information, but it would be interesting to go back and to see. It would definitely be interesting for future studies as well, because you're absolutely right. Yeah. Yeah. And then you mentioned. Yeah.
So Alexa, this is a fabulous presentation. Thank you. Obviously, you're going to be a great physician champion for us going forward. And I'm wondering, what do you think of the future of primary care for PAs being one of the lead care providers? Because I noticed in your study, you talk a lot about, or the focus was not our NPs and PAs like each other, but that which primary care provider, MD versus PA, what's the perception there? So for you, forecasting in the future and looking at what's happening in the States, do you think that we will become more of a primary lead as PAs?
If it was up to me, I would say yes, like 100%. I do think we tend to follow a lot of things that the States does, but I think a major barrier that's in our way is funding. Honestly, the funding of the healthcare system in Canada is really not good. A lot of providers are significantly underpaid. And I think that is a very big barrier to PA integration, because the work that PAs do is very similar to the work that doctors do. And I personally think that, you know, the funding is definitely not where it should be. And not only does that impact, people's personal salaries, but also it impacts the positions that are available. We are lucky that we have a surplus of positions right now, but we could definitely use a lot more. But I would like it to definitely go into the same direction that it's going with in the States. I think that would be super helpful. But I think one barrier we really need to cross is funding, because that's kind of a major issue in our way. What the solution is, I don't know, but hopefully I will continue to do, I still want to continue to do a lot more PA research, because I think it's a very, very big help, especially when it comes to interprofessional team-based care. I think there's so much value in that. And so that's something I definitely want to push forward, not only in my own practice, but in, the healthcare system in general. So yeah, I think the biggest barrier is funding. And once we cross that barrier, I definitely think that, integration could definitely move forward. Yes.
The lack of reimbursement for my fees, for like, I can't bill
Yeah.
for the visit that I did start to finish. So the doc I work with, we're costing a lot of money, and I'm like, yo, that's good, because I'm actually using the patient volume, but it's very nice to have some sort of reimbursement for services, and I don't think that you can have a full primary care clinic run by FDA being super sustainable, especially if you're going to compete without reimbursement. I think it's a little regular on. So I think that's one thing that you really need to work on, being able to be funded through the healthcare agencies, because until then, that's the discussion that we're bringing on the practice.
Right. As a student, I'm not too familiar with the intricacies of how like the billing works and everything, but I do know PAs can't bill to OHIP, right? Or yes. So that probably just costs people not only money, but also time. Yeah, which is very frustrating. It makes no sense. Honestly, that's another barrier that we do need to cross. Again, in terms of the solution, I don't know, but I can tell you that as I go through my personal training, I definitely think PAs have a lot to bring to the table, and I will definitely advocate for all of those changes in the future. So feel free to connect with me if you would like, but yeah. All right. Yeah. It's a great question. So personally, I don't really know how to access the politicians. I actually go to school at the University of Ottawa. So there is actually like health policy interest groups and things like that. I've only been in medical school for 2 months. So I'm still just trying to like learn all of the material and get used to things. But that is a great idea. And I'm really glad that you brought it up, because it's definitely something I can bring forward. And I know like as a future physician, I definitely want to be a clinician, but I also want to work in other areas. So for example, like health policy research, things like that. So these are all things that can go into my practice for sure. Yeah.
Just curiosity. Where you got satisfaction.
Yeah, so that is a great question. I've definitely thought about expanding this study. When I was brought on before the data collection period, but afterwards it was primarily just me working on the study, which I totally can do. But now just kind of with my personal responsibilities being like split into 50 avenues, it's something that I haven't looked into too much yet, but I've definitely thought about expanding the study. And I did talk to Kristen Burrows, my PI on it. And she was interested too. It's something that was definitely talked about. And in terms of taking action on it, I definitely want to see kind of what she says. We're still in the process of actually publishing this paper. So once it's all published, we can definitely see where we can expand. But I think there's so many different ways to take this study. There's so many questions still unanswered, like we've discussed. And so, yeah, you make a great point in terms of expanding it. Definitely think there's potential for that. Any more questions? No. Oh, yeah. That's okay. Mhm.
There are a lot of their work that are aware of PAs and what they do, or is that something that you kind of
Yeah.
Getting more doctors. Understand.
Yeah, I completely agree. It's actually very funny you brought that up because when I started med school, we started, taking histories and doing physical exams, and I already learned a lot about that, right? So people are like, wow, like, how do you know this stuff? And I was like, well, I was in PA school, and they said, oh, PA, what's that? So you actually know what? Not many, at least medical students in my year knew what PAs are, but now that I'm there, they know, trust me, they know. It's funny. Sometimes I'll like walk in with my PA sweater and they're like, oh, yep, you're the PA. So it's funny when I'm in med school, I still feel kind of like a PA, but I like it. But yes, I'm definitely advocating to my classmates. I can tell you all my classmates know, and even my preceptors are actually quite impressed. I have quite a few preceptors that actually pulled me aside and asked me more and are like, well, where can I find these? And then I'm like, oh, well, look on the Facebook group, this is where we post all of the jobs and things like that. So it really is about kind of getting the word out there. And unfortunately, it's not as well known, at least in my school, as I would have liked. But now that I'm there, people definitely know. Any more questions? No? All right. Thank you so much. Thank you. Oh, actually, I'm right this way.
Okay, thank you, Alexa. That was a fantastic presentation and such useful research that once it's published, we'll be spreading that everywhere. I just need to let you all know that there was a slight error in the program and that we would like to start the annual members meeting in the big room next door at 3:30. So if you could all come over there at 3:30 to start the meeting earlier than we had in the program. But thank you all for this afternoon.